Hi, my name's Dr. Bruce Quinn, and I'm a physician and a full-time expert on Medicare policy for innovative technologies. On March 24th, I was invited to speak at the 4th Annual SoCal Bio Digital Health Conference, which was a really excellent conference all 3 days. And I was on this panel talking about digital health, regulatory, and reimbursement issues. I was on the panel with several excellent speakers: Rick Ganota, the Chief Healthcare Officer for Masimo, which was an early leader in pulse oximetry and many other kinds of monitoring devices now; Vivek Thakar, who is a program director for personalized healthcare and digital health at Genentech; and Evan Siegel, who's president and CEO of Ground Zero Pharmaceuticals, a regulatory consultancy. Here's my title slide: Digital Health and Regulation, the reimbursement angle. And I'll give a quick overview of what I talked about. In terms of trends in reimbursement, the COVID pandemic has been an enormous boost to telemedicine. It's required numerous regulatory changes on the delivery and reimbursement side that many people may not have been aware of. They were just aware of the boom. But in order to do that, just in Medicare, where I work, they changed the site regulations. Medicare had very restrictive site regulations for telemedicine. The patient had to be in a rural area or a special federally qualified health center. So it was designed to bring maybe a rural patient into contact with a specialist in a city. But they just stopped that rule. So the patient could be anywhere, the doctor could be anywhere. This was like the fall of the Berlin Wall. Suddenly there's a radical change in the rules for everyone. Medicare also raised the payment rate substantially by about 30%. Medicare had historically paid for telemedicine visits at something called the, quote, facility rate, which is about 70% of the regular rate. So if a doctor's office visit was in an office was $100, in a facility it was $70. The doctor got paid $70. And they also waived the copay. So the rates went up and the sites could be anywhere. The MedPAC is a longstanding federal policy advisory group that's been around for years. They advise both the Medicare agency and the Congress on Medicare issues. And they recommend we continue this policy after the COVID epidemic for several years and observe, what the changes in healthcare are. But also they recommended, as soon as the epidemic is over, lowering the payment rate for telemedicine visits somewhat. So it would go from $100 back to $70, or from $150 down to $110. Now, other issues remain. That was about pure telemedicine, essentially the equivalent of an office visit. But Medicare and other health plans are governed by benefit categories that have their own payment, they have their own rules, they have their own coding. So it's different for surgeries, for office visits, for drugs, for ambulance trips, for durable medical equipment. All of these have this body of rules, regulations, and fee schedules for Medicare that have built up over decades. You could almost say generations. Well, digital health suddenly introduces an enormous amount of innovation, much faster than the system was prepared to accept it. So they class some things as essentially overhead and not paid separately. Anything that goes in through an EHR, generally anything that they think is clinical decision support, they view as sort of an overhead or an enhancement to the office, not as something separately payable. The area of AI and pathology is booming now very rapidly, but there are really no codes for that except some 10 or 15-year-old codes for computer cell counting on a microscope slide. That's not really AI in pathology. And in rulemaking in December 2020, CMS said, frankly, we admit we don't know how to value AI. They were talking about, I believe, a retinal exam technology that could be done remotely and involved artificial intelligence software. And I believe the company had wanted a $25 or $50 per click royalty fee for every service. And CMS is just not willing to accept that into its pricing structure, at least not yet. So I'm sure that's still being debated. Companies like iRhythm and HeartFlow have attracted a lot of investment. iRhythm is a publicly held company worth several $billion. And they've gotten coding, but CMS has had difficulties in setting prices for them. One place where I found an example, there is diagnostic software for MRI mammography, not for any MRI, but only for MRI mammography. And if you do MRI mammography, they build in about a $20 fee for diagnostic software. $12 fee for diagnostic software. But in fact, it's because mammography is something special. If it was used in all kinds of MRI, then they wouldn't build in a special fee. That's how the rules work. So a lot of puzzles here that remain to be worked out. And there are areas like prescription digital therapeutics. This is software often used for 4 weeks or 12 weeks that actually is documented by the FDA to cause an improvement in some health outcomes. So it's on-label medical device. They may involve being doctor prescription only. And there's really no Medicare benefit category for them, or no obvious one. So last year, several senators introduced legislation to force or to create a Medicare benefit category for prescription digital therapeutics. Didn't get passed, but I'm sure those sponsors are working at it again this year. So there is a lot going on in digital health, but it can quickly become pretty complicated, and it seems to move slower than people would like. And with that, I landed on my question and answer slide in the actual live conference. I hope you enjoyed this, and thanks for watching.